Hi, my name is Atif Darush, professor and consultant of obstetrics and gynecology. In this short lecture, I would like to show you how to perform laparoscopic as well as hysteroscopic myomectomy in the same session for the same patient. We present a case who was 37-year-old. She had two deliveries normally, and now she's divorced and had a history of open myomectomy 5 years ago. And she comes to the clinic with menorrhagia and with blood clots, severe attack of for 15 days, and severe abdominal pain, in addition to severe anemia, and the hemoglobin dropped to 7.25. And after referral to the hematology unit, the hemoglobin became 11.3 grams, and the body mass index was 29. On ultrasound examination, the uterus was enlarged due to a posterior wall myoma, which was around 33 by 26 millimeter, and in the endometrial cavity, there are three myomata ranging the size between 3 centimeters to 2.5 centimeters with a suspected endometrial polyp as well. Now, the decision of endoscopic management was made after proper preparation. We started by laparoscopy, as I already published a letter to the editor that all procedures of combined laparoscopy and hysteroscopy is better to be started by laparoscopy due to many advantages. And in this particular case, laparoscopic approach firstly is advantageous as allows continuous monitoring of the hysteroscopic procedure of excision of three myomata. And the laparoscopic part of the operation started by evaluation of the uterus, which was enlarged, big sized, with irregular surface and congested surface as well. After evaluation of the uterus and pelvis, the next step is to inject a vasoconstrictor substance to the uterus to minimize bleeding, and this vasoconstrictor can be vasopressin or diluted adrenaline or other substances to have. And after blanching of the uterus, this means that the uterus started to be, the blood vessels started to be closed, so you can apply the harmonic scalpel to make hysterotomy incision on the myoma, guided by the clinical and the sonographic findings. So after opening the serosa and muscular layer or myometrium of the uterus, you start to see the myoma. And once the myoma appears, the pseudocapsule should be dissected and should not be included with the myoma during its extraction. Thereafter, a 10 millimeter myoma driller is inserted, and its screw was put inside the myoma, and it should be extracted outside from the uterus with hemostasis of the base of the myoma using the same harmonic scalpel. Thereafter, suturing of the hysterotomy incision using continuous V-lock suture with a look at its end to look the beginning of the suture, and then you continue continuous suture. And in this channel, you will find a lecture on the advantages of using V-lock for laparoscopic myomectomy. And after closure of the uterine defect, the appearance of the uterus is like this view. You can put adhesion preventive sheath after proper suction irrigation of the peritoneal cavity. And this is the first part of the operation. The second part, by hysteroscopy, you start by diagnostic hysteroscopy, choose some blood clots, and there is a huge myoma coming from the anterior wall of the uterus, and actually you have to evaluate the myoma until its base, and then introduction of the operative hysteroscopy, which is the resectoscope, bipolar resectoscope, is done to cut the myoma into pieces, which is a morcellation technique. And the myoma is excised piece by piece, and pressure of the uterus should be maintained to the least possible to minimize excessive fluid intravasation. Even if you are using saline, the deficit during saline or bipolar septoscopy should not exceed 2.5 liters. Here is the second myoma starts to be seen, and we start to cut it by the resectoscope, the same procedure, morcellation technique, and once you start to cut its surface, it appears, it bulges through the cavity, and you start to continue excision of the myoma until its base. And thereafter, you will see another one, which is seen here on left side ups, which is the third myoma. This is still the second myoma. Became big after opening of the capsule and starts to bulge into the endometrial cavity. And this is the third one that should be excised as well, and started by morcellation, cutting it. Once you open the capsule, the myoma bulges into the cavity, and you can minimize the intrauterine pressure to help its bulge through the cavity and to excise it. So by this way, you can excise more than one myoma. Here are 3 myomata and the laparoscopic approach. All of these procedures can be done safely under laparoscopic procedure, under laparoscopic control in the same session. And here are the shape of the tissues removed by hysteroscopy of the 3 submucous myomata, and this is the laparoscopic myomectomy specimen after morcellation by the laparoscope. So in conclusion of this short video, I would say that concomitant laparoscopic and hysteroscopic myomectomy is feasible. Starting with laparoscopic part is advantageous and adds a valuable safety monitoring tool for hysteroscopic part. And thank you so much.